Hello, I'm Anton Pozniak from the Chelsea Westminster Hospital and the London School. And today I'm going to talk about Mpox treatment and prevention. So I'm going to give an outline, a little bit about the epidemiology and the clinical picture, and then we're going to talk about treatment of Mpox and then some issues around behavior, drugs and vaccines for prevention. So Mpox is genetically related to other viruses that are more well known, perhaps, like smallpox, cowpox, vaccinia, and canarypox. And here it is on the evolutionary tree. Now, it was discovered in around 1958 when monkeys from Singapore were sent to Denmark, and von Magnus discovered this virus when the monkeys got sick with a rash. There were further outbreaks in the Serum Institute, and we really didn't see any cases in humans until 1970, when the first case was found in West Africa in a 9-month-old boy. And the virus is now divided into two different clades, clade 2 and clade 1. The transmission cycle is probably around rodents. Rodents carry the virus, they transmit it to both monkeys and humans, and then humans pass it from person to person. So this is the transmission cycle that's been proposed. Now, why did it re-emerge and come out of Africa into the rest of the world that we've seen in the last 8 to 9 months? Well, if you look at some of this data from Nigeria, you can see that there were outbreaks in various states of Nigeria all the way from 71 up to around 2019. And then you can see in 2019 a case was basically exported out, and a male in Singapore, and then some adult males in the UK also had monkeypox. And then further on, you can see in 2022, we can see basically this explosion of cases that came out of West Africa, firstly into Europe, and then into mainly North and South America. And of course, it spread through the world in many, many countries. And travel, of course, has been one of the major issues for this. And it's very interesting that many of the cases don't have a travel history for West Africa. The majority don't now. It's been person-to-person transmission in the countries where it's been found. And we can see globally up until recently, so beginning of the year, with 84,000 cases, more or less. But the death rate is very small, 75 deaths, and there now have been 110 countries reporting cases. The numbers have been going down, though. Most of the patients who have been infected with monkeypox have been MSM, but there's been a little fraction that's been grown with no MSM contact, but it's been very small. And you can see here on the right, the global monkeypox weekly cases started really to decline after August, September of this year. So the number of cases is going down. The clinical presentation is like a lot of viral illnesses with chills, muscle pains, backache, headache, fatigue and fever, but there are lymph nodes and skin lesions can be quite characteristic. And it's interesting that some of the key points now about the clinical presentation, incubation period, the mean is about just over a week, 8.5 days. And there's been a loss of the classic pattern that was seen in Africa of an invasive phase followed by an eruptive phase with the rash. There have been lower rates and lengths of prodromal symptoms. You're going straight to the rash in some people, and the coexistence of lots of lesions with all different sorts of morphology. Before it was one morphology followed by another as the lesions all over developed at the same rate. And we've seen more now skin lesions concentrated to the anogenital regions and frequent mucosal involvement. The hospitalization rates luckily have been low. Here is the eruptive phase on genitalia here and around. You can see these lesions starting to erupt perianally. These are mainly genital lesions, and you can see here on the hand. And we've had patients who've just appeared with one lesion on their forehead, and it was monkeypox. So it's very interesting presentations, and they take about 2 weeks to heal. And you can get complications in the rectum and perianally, around the mouth and tongue, so you can't swallow, or you have severe anal or rectal pain. And these are some of the serious complications of Mpox. Ocular complications also occur, but they're more in children and more in Africa. So this is the virus. It's got an outer envelope with these, and then it's got this core nuclear protein complex with fibrils and a membrane. So this is the Mpox structure. And the life cycle of Mpox, there's an enveloped virion which comes into the cell by fusion, and another type of virion, the mature virion, which comes in by micropinocytosis. And then you can see here the DNA replication, and then the rebuilding of the virus, and then it's released by either lysis or exocytosis. And you can see this is all happening in the cytoplasm. So why is that important? Well, it's because of pox virus therapy and treatment. There have been 3 US FDA-approved drugs for the treatment of smallpox, and they basically follow this animal rule type approval that if it works in animals, it probably will work in humans, but it's only based on animal data and not based on human clinical trials. But because of the seriousness, of course, of smallpox, these things have been approved: tecovirimat, cidofovir, and brincidofovir. And there have been 2 vaccines also for the prevention of this. And the current outbreak of Mpox, we had very little data on the usefulness, utility, and efficacy of these drugs or these vaccines. So what about the treatment options? Well, so far we have tecovirimat, which has been approved for smallpox, and it's also been authorized by the Europeans under exceptional circumstances and compassionate use as the FDA for the treatment of monkeypox. We have cidofovir and brincidofovir, and vaccinia immunoglobulin, which could be considered in severe cases, and especially with people with T-cell dysfunction. So there are some other antiviral drugs being used for Mpox. I've put a list here, and it's interesting that ribavirin has been, and some of you may remember HPMA, etc. So some of them are on the agenda and being investigated. So let's talk about tecovirimat. It's been approved for smallpox since 2018. It basically stops the virus binding to Golgi-associated membranes in the cytoplasm. And for those of you interested in structure, here it is. The clinical experience in humans is small. It's really been in treatment of severe or disseminated vaccinia infection. And there are some experience anecdotally now through the Mpox outbreak. Randomized clinical trials are ongoing for Mpox and tecovirimat, but obviously they'd be very difficult to recruit to with the number of cases going down. Here's how you take it. It's 3 200 milligram capsules twice a day for 14 days. The adverse reactions are small. So, some people get headache or nausea or GI upset. You can have it intravenously, and you shouldn't give it to people with renal impairment. And it is a weak inducer of cytochrome P453A4. The adverse events in this PK study, you can see here between placebo and tecovirimat, basically the percentage of adverse events was very similar between placebo and tecovirimat. So it's a drug that I think we've been quite confident isn't going to cause really serious side effects, although it's not been given to thousands of people. For those of you who are HIV physicians who are interested in drug interactions, it's really rilpivirine is the one that we have to watch out for here in orange, and you might consider increasing the rilpivirine to 50 milligrams a day from 25, but I think that probably the best thing to do is try and switch the therapy over if possible and not use rilpivirine. And obviously don't start anybody on long-acting rilpivirine if they're on tecovirimat. What about cidofovir and brincidofovir? Well, we know cidofovir very well because of its use for CMV in the past. It's got dose-limiting nephrotoxicity. Brincidofovir is an oral available prodrug of cidofovir, and that's got reduced nephrotoxicity. But the current availability of brincidofovir is very limited. And I've not seen any big studies yet in monkeypox and mpox, sorry, with pseudophobia. Vaccine immunoglobulin, there's no real data on this, but you could consider using it in people who have got severe T cell function impairment and severe immunodeficiency, for people who've had various chemotherapies, or in HIV and severe immune deficiency. And there's a couple of case reports. One here, a person who had leukemia and a smallpox vaccination and was given tecovirimat as a preemptive prophylaxis, and another about a progressive vaccinia case given vaccinia immunoglobulin. So we've really only got anecdotal descriptions. There is a topical therapy for people who get ocular lesions, and this is trifluridine. So there is something in people with bad eye complications you can give. So who needs a treatment? Who needs to be given mpox treatment? Well, obviously people with severe disease, or people who might be at risk of severe disease. They may have one or two lesions, but they may progress. And these obviously are people with immunocompromise, young children, younger than 8 years of age, people who have got severe skin problems where the mpox may get into the skin lesions that are already existing, and obviously pregnant or breastfeeding women, but we have little data on teratogenicity of these drugs. The other persons who may want or need treatment are those who've got anatomic areas which may result in serious sequelae, scarring strictures, for example, esophageal or upper pharyngeal, laryngeal lesions, or rectal or perianal lesions. I think these are the sorts of patients that we would be treating. Now, what about prevention? The basic principles are really trying to minimize or avoiding stigmatization so that people can come forward, say that they've got mpox, and talk to us about their partners, etc., so we can start doing a public health prevention, promptly treat those infected, and provide post-exposure management to those who've been exposed. And as I say, a lot of public health movements for the prevention, and increased our community awareness and wider surveillance. And this happened a lot in many countries, including my own here in the UK, the US, etc. And there are some infection control practices for those of you in clinical or hospital settings. Obviously, avoid direct skin or mucous membrane contact. And we tell patients, of course, to avoid this. Also, because of fomites being infected, direct and indirect contact with surfaces and items that may be contaminated from active lesions. And respiratory droplets is another way it can be transmitted, so keep 1 meter away. As I say, in healthcare settings, segregate cases, private rooms, hand hygiene. We know all about this from the COVID pandemic, and also PPE with gowns, gloves, and masks, N95s or FFP2s. And cleaning, disinfecting the environment after somebody's been there, and also waste management. So all of those things, and really you have to keep the precautions going until the scabs, the lesions have healed, scabs are separated, and it looks like the skin's starting to now form a new layer. What about behavior change? Is that something we can do for prevention? Well, it's interesting that one-time sexual partnerships account for about 3% of daily sexual partnerships and about 16% of daily sex acts, and approximately 50% of the daily mpox transmissions. So if we can cut these down, we can cut the transmissions. So if you decrease one-time partnerships by 40%, you could decrease the numbers of people infected by 20 to 31%. It would also delay the spread of the outbreak, so you can move in with your public health measures, and you can increase the number of days needed to reach a given level of infection, so that you get more time to give vaccination to susceptible people. So by stretching the epidemic out, delaying the spread, you can actually start vaccinating. And also, you may be able to, apart from the vaccination, be able to test people in a better time frame. So all of this is effective if you can change behavior. But has it happened? If we look here, sexual behavior change since learning about the Mpox outbreak, here's a study of 824 MSMs who completed an online survey on sexual behavior once they'd learnt about the Mpox outbreak. Nearly half reported reducing the number of sex partners, 50% reported reducing the one-time sexual encounters, and 50% reported reducing sex with partners met on dating apps or at sex venues. So yes, behavior can make an impact, and I'm sure we will see in the future the impact this has made in the decreasing number of cases that we've seen. Contact tracing, what about this? Well, we provide contacts with information. It's very passive monitoring, basically. We tell people to avoid sexual or intimate contact or other activities involving skin-to-skin contact for 21 days from the last exposure. Of course, avoid contact with immunosuppressed and pregnant women, again, and children, again, for 21 days. And if you are a contact, you might be considered excluded from work if you're working with immunocompromised people, pregnant women or children. Contacts with children don't need exclusion from school, and we also say don't travel. Now, what about the vaccines to prevent smallpox? Well, there are two. There's the ACAM2000, but this is a replication-competent live virus vaccine, and there is a risk of eczema vaccinatum. Also, we've seen myocarditis. It does work, though, against smallpox, obviously, and there have been animal models to show protection against monkeypox. But then there's the Jynneos Imvanex. Imvanex is a European name, Jynneos elsewhere, and especially in the US. And this is replication defective. It's a live virus vaccine, so there's no risk of dissemination. So for those people who may have some immunocompromise or severe skin problems, it's the best option, and animal models show protection, though we don't have really much human data. And here's the comparison, just to put there, replication competent versus deficient. Can you get problems with inadvertent inoculation and auto-inoculation? With the Jynneos, no, but with the live vaccine, yes. Serious adverse events, much more with the ACAM2000 than with the Jynneos. Here's the myocarditis, and the effectiveness is mainly being from Mpox in animals. And the administration here, you have to use a special bifurcated needle for the ACAM2000. Some of you may remember this, with a single dose. But the Jynneos is subcutaneously, 2 doses, 28 days apart. Here's some complications of the ACAM2000 when it gets into various skin diseases, and this is disseminated vaccinia now, and you can see other pictures here of skin disease as a complication of a live replicating virus. What about the dosing regimens for Jynneos? So this is very interesting. So people who are more than 18, subcutaneous, 0.5 ml, 2 doses, 4 weeks apart. And if you're under 18, again, it's basically subcutaneous, 0.5 ml, 28 days apart. But when you can look here that in the people who are more than 18 years old, you can give intradermal and give 0.1 ml. Which is really interesting. You can mix and match these, and you can give, obviously, 5 more people a vaccine by doing it intradermally. The problem is that once you've opened the vial, you have to finish it off. You can't just put it back in the fridge and wait till tomorrow. Pre-exposure prophylaxis, so vaccination can be considered for persons determined to be at high risk for infection. So this is what people have been doing, especially gay and bisexual men who have sex with men, those who have high-risk behavior. We know who those are in HIV because they're the people that come for pre-exposure prophylaxis. But actually, this has been applied now regardless of HIV status. So HIV patients have been targeted to be given pre-exposure prophylaxis, and also those with high-risk behavior. And it's been moved out now to anybody who feels they need the vaccine. In some countries, they have been given the vaccine. So here are risk criteria if you want to use that: a recent history of multiple partners, participating in group sex, attending sex on premises, venues as a proxy marker. We've used also STIs in the past year. Obviously, people who have occupational exposure to orthopox viruses, lab personnel, people doing diagnostic testing, and obviously healthcare professionals who are looking after or screening patients who might have Mpox. As I say, you can the post-exposure prophylaxis can also be given as well as pre-exposure prophylaxis, and the post-exposure can be given up to 14 days post. But if possible, give it within 4 days. After 4 days, and between 4 and 14, it minimizes symptoms, but it doesn't prevent infection. If you can give it within 4 days, you may prevent infection. So PEP and PrEP, both useful using this vaccine. And there's a lot of guidance, CDC guidance here, vaccination after known exposure to monkeypox, so that's one thing. And there's now, they've expanded that, vaccination after known or presumed, and they've put some of the criteria for presumed, people who've been to sex parties, multiple sex partners, etc. So if there is enough vaccine, not only have we been vaccinating our HIV population, but we've also been vaccinated our MSM population, even those, obviously those at high risk first, but even those who have a relatively lower risk. Now, what about people living with HIV and vaccination? Well, again, for post-exposure vaccination, ideally within 4 days. What we've been using is the Genius, well, we call it Invanex here, replicant modified vaccinia virus. So it's replication deficient, as I've said. And we've either been using 0.5 ml subcutaneously, can be given IM, or 0.1 ml intradermally, depending on supplies. And the second dose after 28 days. And that's for people with CD4s more than 200. And for those with a CD4 count less than 200, we've only been using the subcutaneous 0.5 ml dose. We haven't been using the intradermal dose. And the ACAM 2000, basically, we do not use in patients who've got HIV, whether their immune systems are good or bad. So, in summary, for treatment, we have some interesting drugs, but tecovirimat is the one that we've used mainly, but cidofovir, brincidofovir can also be used. For prevention, there's a PrEP, which is mainly using the non-replicant vaccine, the Genius Invanex, and for post-exposure prophylaxis, especially within the first 4 days, we can also use the vaccine. And the other thing that I think has made an impact is changing behavior, but the actual size of that impact we don't know, and I'm sure it will be measured and we'll know. But Mpox looks like it's on the way down, but we do have now some treatments and vaccines which we can use and rapidly implement for both the treatment and prevention of Mpox. And with that, I'd like to thank you very much indeed.
Thank you very much, Anton, for that great presentation. I think we have a couple of questions.
Hi, Anton. This is Annette Sohn from Treat Asia. Hi. Question for you. One is about, actually two questions. First is about vaccine protection and duration of protection. Could you share about how long that's expected to last? And then the second question is about, now that fortunately there's so few cases, you already mentioned that the current clinical trials are not really enrolling. So what do you see as the future for treatment? Thank you.
Yeah, Annette, I think that the issue now with the clinical trials is we won't have it. I don't think, we're going to have any data that's going to be significant from the trials that are running. So I think we're going to stick with tecovirimat as the first choice. And the major place where we might get data from is from the African epidemics, because they're now getting access to the drug and they're running trials there. But I don't know how long that data will take to come. So I think that the only way we're really going to get data is from where it's been running its course for many, many years. So that's the first thing. And they are doing trials in tecovirimat, so let's hope we get good data from there in the next year or so. The vaccine issues, first of all, there were people who used to say that if you'd had a smallpox vaccine, it may protect you against monkeypox. But we really don't have any definitive data to say that's the case. And people have been doing some, looking at some immune responses. And I think that the major issue for us is the vaccine has to last long enough for the epidemic to disappear. We hope that 2 doses will give you lifelong immunity, but we don't know. As I say, there's been so little human use of the Immunovax vaccine in monkeypox. That data, I think, will only probably come out in the next few years, because what will have to happen is all those people who have been vaccinated, we just have to look at their antibody responses in vitro as the years go by. But as I say, whether smallpox vaccine really does protect you from monkeypox, it's an unknown entity. I mean, I've heard people suggest there are and provide some data there are, and others that say that it doesn't and it won't. So I think it's complex, but we'll only really know how long these vaccines last as long as we set up research to look at that over the next 5 to 10 years. It's great questions.
David?
Yes. Hello, Anton. It's David Burker here in Nijmegen, Netherlands.
Hi, David.
It's a pity we don't have you here in Bangkok, but I have a question. What you told us about the drug-drug interaction. So correctly, with the rilpivirine, there could be significant drug interaction. And we are lucky we have the HIV interaction checker from Liverpool that can be helpful. However, tecovirimat is a moderate inducer, can also have interaction with other medications outside HIV. So do you have any experience? Have you seen something in your patients with co-medications where a significant interaction happens? So can you share your experience?
No, well, because the majority of our patients have been relatively young, David. So, I mean, we have had older patients with that. And obviously, we've done the same. We've been in uncharted territory. I mean, even the rilpivirine interaction is just a theoretical one. And so we haven't, and we use the Liverpool website to look at drug interactions, and it's very difficult for us to have done much. The only good thing to say is that probably the induction, by the time the induction comes and disappears again, whether or not your effects, say, on an antihypertensive or anti-lipid drug will have been really significant to a patient's health, I don't know. I mean, the big worry is if you're on chemotherapy or something else that would have a potential interaction. But we have not had that. Mainly, almost, I would say the majority of these people have been otherwise relatively well and not taking drugs. But one of the things I could back to you is about recreational drugs and whether you think that tecovirimat might affect any of the recreational drugs that these guys do take.
Yeah. Okay. So more to study. Thank you, Anton.
Yeah, thanks. And I'm sorry I'm not there with you. I'm living in Brazil at the moment for family reasons.
So look, Anton, thank you so much for staying up late to be online for these questions and for that wonderful presentation.
It's been a pleasure, and thanks for inviting me. Next time, I want to be there in person.
Okay, let's thank Anton.